I just want to point out some specific words that you should sort of have in your word bank and understand what they are, okay? And this right here, we're talking about long bone development. But this could be a phalanges, short bone as well. But the tibia, fibula, femur, humerus, ulna, radius, this is sort of how they develop. And you start out with a sort of a cartilage template model, and then you start developing what's called a primary ossification center. Okay? This is where the bone, you get medullary bone in there, it's trabecular bone, whereas you're getting the compact bone growing here on the outside. Okay? And then after a while, by the time you're born anyway, the later part of embryo development, you start getting the secondary ossification centers in the what's called the epiphysis of the bone. The end of the bone is the epiphysis. The shaft is called the diaphysis, and I've got those written down for you in the next slides. But then they sort of grow together. Okay? And as you get older, you start to lose that cartilage pad between the secondary and the primary center, and then you start to see just a little line like this. And then as you get on later on in adulthood, you may not see that line at all. Okay, but so whenever you see a nice line like that on the X-ray, you know you're probably dealing with somebody under 20. Okay, because usually it's an adolescent that you'll see what they call the epiphyseal plate there, and I'll show you some X-rays of that kind of stuff in the future. So if you can remember primary growth and secondary growth centers, that'll be good. Here's where it labels the diaphysis for you. Okay, that's the shaft basically, and the epiphysis is the end of the bone. The epiphyseal plate right here, that's the name of that cartilage that goes across. Okay, so just those terms. You just know what they are.
What is it now?
The epiphyseal plate. I'm circling it right there. Okay, that's the cartilage plate between the two growth centers. Okay, and I'll show you X-rays of them. Endochondral ossification is the term for long bone development like this, as opposed to intramembranous ossification, where we're talking about flat bones like the cranial bones. Okay, and I've got slides with those names on there too. Okay, so endochondral ossification. Long bone development, right. Here's an X-ray of a fetal hand with mostly cartilage. Okay, I can't even tell you if that's a primary ossification center right there, because I'm pretty sure it's just the way that this slide was made. They cut through the bone and it kind of looks like that. But that is what they look like when they start to develop bone in the center. But you can see these cartilages here, the metacarpals here, have no ossification centers yet. So this is early in development. But you get the cartilage, these are all the carpal bones. Okay, you get that growing in there. And then you start laying down the bone inside these things. Which tells you, for one thing, that without cartilage development, you're not going to get a bone. And so bone development, or should I say cartilage development, is the key to even growing an arm. Okay? For some reason, if the cartilage stem cells turn off, you're not going to get skin with muscles and blood vessels forming an arm. Okay? They come after. They get their growth factors, their transcription factors. They get their growth factors from the cartilage. So unless you have cartilage forming the appendage, you're not going to get the surrounding tissues on it. Okay, so it's critical. So bone growth and cartilage growth, mutations in those growth factors really can change the way a limb looks. Okay.
So that way, some people are born just like half, and then they might have like a little thing over the side.
Exactly. You're never going to see an arm with no bones in it. Okay, that just doesn't happen. All the other tissues are contingent on that cartilage growing. Okay, but that's the reason why you can develop a wing like a bat. Okay, because it's the cartilage growth factors. All you got to do is turn it on a little more and get a little longer finger, and you're going to have that long bone that they use to form the wings. Okay, and the other tissues will follow. Okay, so that's.
Does that also affect the disease where your bones just start deteriorating? I forget what it's like. It's like the bone just starts to degrade. Goodness, if they get their fingers, or like usually their fingers and their toes are the first to go.
Are you thinking about like rheumatoid arthritis or something?
No, it's actually, it's like they said the one patient that I knew, he said his bone was actually starting to deteriorate. And actually, it'll start, it's like the osteo, but he said it was, you know, it just starts going away, like, and then they start to have to cut this off, because this wouldn't.
Unusual. I can't say I know the
I
name
can't
of that
remember
syndrome.
the name of it, I'll have to.
Yeah. There are a couple of diseases where you get sort of deossification of the bone, and you'll see patches in the x-ray where the bone seems to be gone.
Well, that's kind of what he explained,
Yeah,
that's kind of like that.
I'm blanking on the name of that one. But, yeah.
How dangerous is it, or what kind of residual effect do children have when they break their growth plate? Is that what the
That's
empathy?
exactly what you're talking about.
Yeah.
Yeah. And I'll show you some x-rays and we'll talk about that.
Okay.
Yeah. So I'll just skip. This is just a shot of that hyaline cartilage. Down here you've got that cancellous bone, spongy bone that's forming, right? But we don't really have a secondary ossification center in the cartilage here yet. So this is a primary center there. That's sort of the edge, just what it looks like. There we go. Just another shot again, just to give you the words epiphysis and diaphysis. You can see how it's mostly spongy bone in the head, so like the head of the femur and the tibia. It's going to be mostly that cancellous bone, okay, with the compact bone on the sides of the diaphysis here. Okay.
So the compact bone on the outside.
Yeah. It forms the ring of the bone on the outside. Yeah. And you probably saw enough broken bones in the lab to see that spongy bone on the ends of them. Okay, and this is what you're seeing in here is that spongy bone. Again, this is if you look at a 10-year-old, it probably look like this. You look at a 20-year-old, it probably look like this with a thin plate there. A 50-year-old, you might not even be able to see the line. Okay, so it just disappears sometimes. But that's the growth plate, or the epiphyseal plate is what it's called. And here you go. Here's an adolescent, probably 14, something like that.
Wow, yeah.
13, 14. It looks like a fracture. And here's one through the tibia. Here's the growth plate through the tibia. Here's one through the femur. And many medical student and young intern has been fooled by these kind of things, thinking that the patient had a fracture. Okay. And we obviously, I think we know what the bones are here, right? Here's the intercondylar eminence, intercondylar fossa, and the condyles, fibula, that sort of thing. So, but this is typical. When you see these lines, you're dealing with a teenager or even younger.
Okay, say if they do fracture right there along that line somewhere, is
Yeah.
it hard to tell?
Well, it can be, but usually it's not a perfect fracture through the growth plate.
More of an angle?
Yeah, usually you've got a fracture that goes down to it and through it, that kind of thing. But that does affect the growth. I mean, and sometimes it stops the growth of the bone, so you could end up, having one leg that's 3 inches shorter than the other. Okay, and that's why, because you can kill that growth plate. Okay. Here's an adult without those lines. See, see, this is an older adult where the epiphyseal plate is gone. Same angle there. Okay. I just thought I'd throw in rickets because I think college students should know it's caused by calcium or vitamin D deficiency. Okay, this is what it looks like on X-ray. You've got very thin calcification of the bones.
What bone is that?
This is the femur. This is tibia. Fibula.
Wow.
That's when they're bow-legged,
Yes, it will cause a bow-legged look
because my twin sister.
because the
had-
bone's not strong enough to keep straight, and it will start to bow out.
Wow.
Okay. And then you can fix it by giving back the vitamin or the calcium. When I was in Europe, I saw a lot of older folks, in their 80s and 90s with that bow-legged rickets look, because think about when they were young, back in the 20s, 30s, around the war.
Yeah.
There were a lot of food problems back then, so they weren't getting the right minerals and vitamins, and a lot of the older folks had rickets back then. But that's what it looks like. Okay, here's a youngster with it. You can see the growth plates are barely forming because you're not getting much calcification in the epiphysis at all. Okay, but you can see that femur, how curved it is.
And you can straighten that femur up by giving them
Not
vitamins?
really.
So
Not
once
really.
they've done the damage, it's done?
Yeah. Yes, ma'am.
Because like I said, my twin sister had that, but back in the day, they broke her legs and put rods and pins to straighten it out.
You sure it was rickets?
Yes, my twin, she was in a wheelchair. And they broke her leg to fix it, and now she has problems with the arthritis now.
Yeah, well, I wouldn't imagine so.
But back in the day, they broke the leg.
Well, I guess, yeah, I guess if you were young enough and
How long
you know,
was that?
and you could fix it by doing that, you might, but basically, once the curvature is there, it's not gonna fix itself. I mean, you'd have to break it to straighten it, you know, so.
But it's prolonged, right? I mean, for a child to get rickets, it
Oh,
would be
yeah,
prolonged
yeah,
deficiency.
yeah, we're talking, 6 months, a year, in their early bone development, yeah, so.
So the younger they are and they're deficient, the worse it's gonna be.
The more affected they'll be, right?
That's why I meant the
Right,
worse
when
that-
the
that-
crucial moments of bone
Right.
hardening are starting to happen, if you can't do it right, that's the crucial time. Here, besides the endochondral, here's the intramembranous ossification. This is the flat bones of the skull. They grow from a center like this and grow out, just like you were pouring 2 pancakes from 2 cups in a frying pan. You see them start to spread out,
Yeah.
and then when they finally touch, that's where the sutures are going to be. Okay, so that's how they develop like that. And this is a more than pre-birth. This is
Right.
like 12 weeks here.
Oh, okay.
Okay.
So that's before.
By the time they're born, most of this is touching now, but you still got that sphenoid fontanelle and the anterior fontanelle here. Okay, but this is just the difference between long bone development and intramembranous development, because they don't develop that hard what you think of as the osteons. Okay, in this type of bone. This is membranous bone that grows like this. It forms trabecular bone inside this membrane. And this membrane, without the bone, would be what the fontanelle looks like. Okay, the membrane is there, but you can press on it. Sooner or later, though, the bone will develop inside that membrane and close off the suture. Okay. So intramembranous ossification, nothing special, just know what it means. Okay.
So it's all
What it means again?
spongy
What- yeah,
bone?
what-
Flat bones.
Oh,
Flat bones, like the cranial bones, the skull.
And so it's all spongy bone in your skull?
Yeah.
Okay.
Now, I saw something about people, well, it was like a guy, his head, like when he was a baby, it kind of developed like a cone head type thing, because their skull didn't, like, go to, like, the bones didn't develop right.
Right. Oh, you can see all of it. I even, a couple of months ago, I even pulled a slide I saw off the internet with all the different shapes of skulls. They're all normal, modern humans, but their skulls are just, some of them are triangular and some of them are, egg-shaped and apple or pear-shaped. And just depending on the way these bones develop. And one may develop faster than the other, so you're going to get odd
Well,
shapes.
it didn't connect on a certain part, and he had to go get like some kind of surgery, and he was like 9 or 10, I think it's something, it's on his therapy.
Well, if you can imagine something going wrong, it probably has. I mean, you're going to at least see one patient in the world that has something like that.
Ancient civilizations, they sort of used to wrap their heads
Oh, yeah.
and try to make them come
Yeah.
up like that.
Right, right. But you could do it on purpose.
Yeah.
Or put flat boards. They used to put 2 boards, the front and back, and tie the boards together so the head would grow up between them. You have a flat forehead with a big forehead.
No, I mean, that's what they believed, it was like they were supposed to be more intelligent or something.
Oh, yeah, and sometimes it was just the royalty that was allowed to do it. But they found a lot of those kind of heads in, not Mexico, but Peru.
It's kind of like the one thing that they do with the neck,
Yeah.
but it's actually like pushing the shoulders.
Yeah. Well, they are stretching the cervical joints. The disc spaces are widening.
That's just it.
And I'm not going to spend a lot of time, or should I say, I don't want you to spend a lot of time on this. I just want to show you some examples of different types of fractures. Your book talks about bone healing, okay? And you can read that if you want. I'm really not going to test you on it. But the basic idea for bone healing is that you want to get the periosteum back together, okay? When you break a bone, it's not going to heal too well if you've got ends like this. Okay, you want to get the periosteum back together because that's where the healing is going to be taking place. It will grow back together like that, though. Okay, I've seen people who had broken arms that weren't treated well, and their humerus looks like that on an X-ray. okay? And it's pretty solid, it'll go back together. My scapula probably looks like that, because when I broke my scapula, the bottom half slid up underneath the top half, and that's how it stayed, okay? So, I don't know what happened to my subscapularis, but, you know, but my, you can bet
Was there no way to put it back in? Go ahead.
they said it was in too many pieces. So, because the glenoid was broken off, and it was broken in about 5 pieces, and they just said, we don't want to go in there and put a bunch of pins and give you arthritis, you know, that kind of thing. But they said, if you want to take your chances, since you're right-handed, it's not your critical arm, they said, why don't we just leave it alone? So I was lucky that I could even get.
I started saying, it looked
Still
like
got
you use
good
it just
movement,
fine.
right?
It's still, if I think about it, I can still feel the ache, though.
Were you
It's,
young when it happened?
It's got a little ache to it. I can't carry heavy things with this eye. Okay? And I don't know, my deltoid is atrophied a little bit because I don't use it a lot. Okay? So this shoulder's a little flatter than this one. But anyway, that's me. Normal bone, transverse fractures. These are just some terms you'll hear in the ER and on the floor. Oblique fractures, a little angle there. Spiral fractures. These things are usually caused by some sort of twisting, like a ski accident or something, where you take that bone and just go, and it breaks off in really sharp edges, and you get these really pointed things. These are very often what they call open fractures, because that sharp bone will cut through the skin. Okay? The old compound fracture term is not really a medical term. In the medical field, they talk about open fractures. Okay? And anytime you see a broken bone, if there's any skin break at all, they treat it like an open fracture, because if bacteria gets in there and gets on that bone, that's sometimes really hard to get rid of. That's osteomyelitis when that happens. Sometimes people are on antibiotics for months. Okay? And sometimes it never heals. Sometimes you'll actually have a draining fistula with pus coming out of the wound, and it can be that way for years.
Wow.
Okay? So
And
you
that's
really
on
want
what
to keep
kind?
it. That's when the fracture,
Open fracture.
well, open fractures, what they used to call compound fractures,
Yeah.
where the bone breaks and goes through the skin.
Oh,
You really got to keep that clean, and you really got to worry about infection and
so the
contamination.
bone is what messed up?
Yeah, the bone is what pushes through the skin.
And that's what gets infected and stays infected?
Yeah.
But obviously it's the wound that gets infected. The bone is not producing a bacteria.
Oh, right. The bacteria
yeah,
is
it's
on the
coming
bone
from,
from
right.
the outside. Okay.
Right.
One of the weirder fractures I saw where this didn't happen was a guy from Peru, actually. He was flighted up to Galveston when I was there at the Shriners Burns Institute, and the surgeons there wanted to look at his arm. He had fractured his humerus, and if you can imagine, here's his humerus, here's the shoulder. He fractured it, and then it went through his arm up like this. Okay, so he had a really short arm now, but the bone is sticking out of his arm, and they just let it heal that way. So he had this dead, grayish looking horn sticking out of his arm, and his arm was, 3 or 4 inches shorter than it should have been. Okay? So
Why would they let it heal that way?
I wasn't
That's
there.
Peru.
Hey, I'm from Peru.
All of it.
But this wasn't.
that
This wasn't a child. This was an adult,
Right.
and he just had this bony horn sticking out of his arm. And so, another case in Peru that we saw at the institute there, a guy got hit by lightning and burned off the top of his scalp. So we were doing skin grafts and things on him. But he was also from Peru.
Did it happen in Peru or here?
Yeah, he got hit by lightning there, and they sent him up to the Burns Institute in Galveston. So, comminuted fractures, these are crush fractures. This is when a tree or a boulder falls on your leg, or you get hit by a car bumper on a motorcycle. Okay, this is the crushing kind of fracture. These are called comminuted fractures.
Do those heal properly? I mean,
Well,
back to normal?
sometimes you got to pin them back together again. Yeah. It's pretty good to put a plate on there and screw the pieces back together.
Right.
Okay. So they'll call that an open reduction and fixation, where they open the wound, they open the fracture, reduce it by lining. That's what the reduction means, when they put everything back together and then fixate it. Okay. That's an ORIF, open reduction. Internal fixation is what they call that. Okay. Segmental, obviously you're just breaking out a piece of the bone. I never saw much of those. Avulsions, you saw a lot of these, and I'll show you some pictures of them. This is where you either crack a piece of the bone off, or the tendon pulls the bone off. Okay? Because sometimes tendons and ligaments are stronger than the bone, especially if there's growth plates around there. Okay? It'll just pull that whole thing off. impacted is what it sounds like. This is usually older folks that like fall on their hip, and you just take this and you just crush it, okay? So you can have a jagged line of impaction fracture, or sometimes these things are in multiple pieces and it looks almost like a comminuted fracture.
So I was gonna ask what the difference was.
Yeah. This is just, you're just sort of crushing it, but in this particular one, you haven't broken this all into pieces, okay? Torus fracture is sort of a twisting or a crushing kind of thing where you haven't quite broken through the periosteum, okay? And so you get this weird looking thing like
So it's
that.
been compacted.
So the
So what
damage
happens
is in
with
the
that?
inside.
Oh, well, you cast it to give it strength.
But doesn't it get like the calcium
It can.
loss or something?
It can, yeah. You'll get calcium growth there. But very often it'll go back looking normal because the bone remodels
That's what I
itself.
was wondering, yeah.
Yeah.
I had one of those. I fell on my bicycle when I was like 11. And my mom was like, oh, it's not broke. I couldn't use it hardly. But I could still wiggle my fingers, but I couldn't really use my arm at all. And she's like, well, you'll be all right. And she was in nursing school. I was like, oh my God. But it did, I mean, I still have a slight lump.
Yeah,
But for the most part, it took about a month. And it was,
yeah. Well, you probably did get a Colles fracture. Yeah, and you broke the radius there, which is a common fracture. It's called a Colles fracture. All people are falling on their arms and they break their radius. Okay, that's a Colles fracture. Green sticks are usually only seen in kids. Very often you'll see a little line that doesn't go through all the way through the bone, whether it's horizontal like this or oblique. It doesn't really matter. But it's literally what it sounds like. You take a green stick and you try to break it, and it just goes like that.
Oh, and it doesn't break all
And
the
it
way
doesn't break
through.
all the way through.
Right.
And so the ends are still close together. Those things will heal up in 2 weeks sometimes. And you take another x-ray and you can't even see it. Okay? Those are the ones that moms are always saying, that the church, the faith healed my son, or my daughter. 2 weeks, the doctor said it was gone. But, I want to see him heal one of these.
Yeah.
But
Now, why do you
I'll
see
show
him
you.
in children?
I'm sorry?
Why do you see him in children? Because their bones
Because the
are
bone is softer.
Softer, okay.
Softer and younger. It's not as hard and crystalline as the older bones.
Okay.
Okay. These are older bones here. You don't see any significant growth plates here. Although I don't know, that might be right there, and that right there on the fibula. But this is a comminuted fracture of the tib fib. There's the ankle.
That's the open.
There's the talus. Well, we don't know if it's open from the x-ray, but it could be. That sharp piece of bone could have gone through. This is a spiral fracture, nice big sharp piece of bone on the humerus.
Now, do you have to cast all of these?
Oh yeah, oh yeah.
Because, like, my dad broke his ankle, and they didn't really cast it up. They just kind of wrapped it real good.
No. You break it like this, they're gonna have to pin it back together again. But if a lot of broken ankles are just you break off the head of the fibula.
He did it playing softball.
That's typical. Yeah, you roll out on it and you break the head of the fibula off. What you can do there is just put it in sort of a U-shaped air cast, and you don't have to support the whole leg. But you do something like this, you've got to pin all that back together again and put this in a nice cast. Okay.
What is it when you dislocate a bone? What's the difference?
It's out of place.
Okay, so it's just because, as a kid, I dislocated bone. My father yanked my finger, and
Yeah.
that was it.
A lot of dislocated fingers where you can imagine when you pull the phalange off the MP joint and say either stick it back underneath or stick it over.
Okay.
So you see the bone ends don't meet anymore.
Okay.
By dislocation, all you're doing is taking a joint and moving it so it's not connected right.
And so by him yanking out, he basically just
Yeah, well, some of those,
Pop it
yeah.
back into
You
Okay.
can pop it back in place.
Okay.
You can dislocate a shoulder, the humerus comes out of the glenoid, and you'll have a little ball sitting here in front of the shoulder.
Yeah.
And you can push those back in somewhere.
like Mel Gibson in Lethal Weapon.
Yeah.
Okay.
But, there's a trick of what they used to do when people would come in, especially if it was the first time. Some people have chronic dislocations. They have weak ligaments and it comes out, every month, But it's like the first time from an injury. They used to lay you on a table like this with your arm hanging over the table, and they would put weights on your arm to pull it down, and then they would gradually try to work it back into the joint. And they'd give you, a lot of painkillers and Valium while they're doing this. But now there's a neat little trick that I've heard about that what they're doing is you tell the patient, you know, he's sitting there holding his arm, and you tell the patient, you just lay him back on the gurney, and like this, and you tell him, I'm going to go out for a little while. What I want you to do is take your right hand and put it behind your head, if you can, so I can work on your shoulder. And what happens is, if they can work it up there and get it back behind their head, many times it'll pop right back in by itself.
There goes $500.
Well, they save themselves a little money. They save themselves a few orthopedic visits. But that's a neat little trick that I heard about. I've never been able to see it done, but I've read that it works. Okay, let's go here. Where is the fractures here?
Where the arrow's at.
Yeah, where the arrow is.
The one-
The shoulder.
Looks like one.
Yeah.
Here's a spiral fracture that really hasn't moved much, okay? But here's also a fracture through the epiphysis into the growth plate. So this is occasion where you'd have to worry about, you know, what's going to happen with that growth plate.
Damage.
Here's the growth plate on the fibula. So this is a younger person. This is an adolescent. This is not. This is probably much older. The bones are pretty thin.
Yeah.
Somebody probably fell on their shoulder, and they've got what almost looks like a comminuted fracture of the head of the humerus there. You can see it's fractured up here. It's fractured down here. There's pieces around
You
here.
can see the spine and the acromion. You can see all that.
Oh yeah, here's the spine, or that's the clavicle.
The clavicle.
Or the, okay, so it's the front. Okay.
Here's the glenoid. Here's the acromion.
Okay.
The spine would be back here, sort
Back
of.
there.
This darkness, that's part of the spine.
Okay.
Right there. Here's the infraspinatus fossa.
Okay.
Supraspinatus fossa. Here's the glenoid, like I said. And this is what I did with mine. I busted the glenoid like a pie, just into several pieces, and broke it off the scapula, and then broke the scapula in half.
Ooh.
Nothing happened to the humerus, which is what threw me off, because I got off the motorcycle and went.
You had a motorcycle accident?
Yeah. I was over on West Lake Hamilton Road over there doing about 60 and a 25 turn, and I went out into the cow pasture tumbling around. But the first time I hit, I landed on that left shoulder. And when I tried to pick up the bike, it was like, ooh, that hurts. And so, but I thought, I didn't break my arm. And so I went home, got cleaned up, and called the trailer to come pick it up, and we called the cops, and I got my ticket. And but that night, I'm like, I gotta go get this X-ray because it's starting to hurt, you know. And I went to the back of the ER, a friend of mine, and I asked him. I said, hey, so give me an X-ray. I need to look at my shoulder. So I think I dislocated it or something. And he comes back with the X-ray and he goes, you didn't dislocate it. And we were like, oh. But there were pieces all over the place.
My son's actually going on his 4th surgery right now.
For
He basically was trying to be smart going down a hill on his bike, and he went over. He fractured his distal radius in 3 places. So yeah, the original surgery was the plate and screws, and then he had to have all that removed. For the 3rd surgery, because his growth plate died on his wrist, he had to go down and shave the good side of the bone to match the hand. Now once he's 18 now, a couple more years, the 4th surgery will be actually to even out the hand. Right now his hand sits like that.
yeah, because the ulnar is longer than the radius.
That was going to be one of my questions. What happens, like on the tibia and fibula, if one is the growth plate is affected but the other's not? One continues to grow and the other one will stop.
One side of his wrist is actually
It's gonna be longer.
The bone's growing more than the dead side, so he's actually sitting like that.
Yeah, you can just use your imagination what's going to happen.
Yeah,
So they have to go in and even these things out and fix them. And they'll either try to get one bone to lengthen or they'll shorten the other one. Okay. Here's a nice little, looks like oblique. It's a little oblique fracture there. With that, I almost call that a spiral fracture with all these shards of bone like that. This is like a typical skiing accident.
So you said that's an oblique or spiral?
More spiral when you look at this big shard there.
Okay.
Here's more or less a transverse or oblique, but what bone are we talking about here? What?
that's
That look like the humerus.
yeah.
Yeah, that's the humerus. There's the trochlea, or the piscinus. here's the ulnar notch,
Yeah,
the
the
olecranon
olecranon.
coronoid process here. And just broke the whole end of the humerus off there.
Oh.
That's an elbow fracture.
Yeah.
Very often you'll see dislocations. You're talking about dislocations. You have the humerus here, you have the ulna here, and it'll dislocate like that. Okay? And
I seen that.
somebody would say something.
We saw a lot of those. I work at Zephyr Hills too, and there's a dive place out there where they jump out of planes. Lots of those.
A lot of those hitting the ground too hard.
Yeah.
Yeah.
A lot of people from overseas will come over, and like we had this guy from England. He snapped his leg.
Yeah.
I mean, and the bone poked right out. You can see it.
Yeah.
Well, they were like,
Open fracture.
A big caca.
Here's a green stick. Okay, it's not going all the way through the radius there. This is a little bit further down. We tend to call them Colles fractures, but this is a green stick of the mid radius here. You just straighten that out. You just use a little pressure on it, wrap it up, put it in a cast, and in 2 weeks you probably won't be able to see that. Okay, they heal up nice. Here's a very young one with a big growth plate here. Okay, you can see that the head of the fibula hasn't even touched the tibia yet. Okay? But there's a little crush fracture here, okay, called a buccal fracture. And this is one reason I would just say, you don't have to know about buccal fractures, but this is why you get shots of both legs and both hands and both feet when you're trying to figure out if something's fractured, because you want to compare them. Okay? And the only way that you really kind of notice that, you could miss that pretty easily without seeing the other side. Okay? So,
How old were you?
You mean that steep curve in it?
oh, that's under, that's probably 5 years old. That's when you see growth plates like that. Yes, ma'am?
You mean in that steep curve that was on that buccal fracture? Right there, that steep curve?
Yeah, that lump right there,
Oh,
It almost looks like a tuberosity from
that's bone
little
that
tubercle.
has been pushed out just because of sort of a crush injury.
Oh, okay.
And you could see something like this, a kid jumps off a roof or something and hits the ground just like those, or falls out of a tree on his legs.
But if he's that young,
We did. Well, not.
it,
They're not gonna
just
do much of
saying
that.
if he's 5,
Yeah.
he wasn't climbing the tree.
jump
So
around the
no,
bed.
No, my
Climbing trees at 5 years old.
When I was 5 years old, I was up in 50-foot trees.
Yeah. I was 5 first when I had stitches.
But, even just falling off the second bed in the bunk beds,
Okay, that's what
Yeah.
I'm saying. I mean,
it
What
doesn't
else
take
would
much
cause
sometimes. Okay. So, this is kind of a typical ankle fracture that I was telling you about, where you roll out, you invert it, and you break off the head of the fibula, okay? Because the ligament is strong enough to crack that bone. The ligament will hold it there, but these have been torn here. Sometimes you'll tear the others. Very often, when you roll out on it, you're tearing the outside and pulling the fibula loose, but you're also crushing the other side. You're crushing this and breaking this off. Okay, so this is when you get both fractures. Okay, but this is kind of a typical look here too. The fibula, even part of the fibula has been pulled off by the tendon. Here's tendon, and there's bone, and it's been pulled off of the fibula here. So this is an avulsion fracture as well as the other types of fractures. The ligament is probably still attached here. It just pulled the medial malleolus off.
What about like a sprain?
That's what I was just gonna.
Sprain is when you just do something like this.
Okay.
That's when you tear the tendons. And you really don't even call it much of a sprain unless you get bruising, because then you've torn something and you're going to get bleeding, and that's when it turns a little black and blue around the ankle.
So do tendons, can you do anything about that, or do they heal themselves?
Well, if it's
They grow back together?
relatively minor, they'll just leave it alone. They might put you in one of those little ear splints just to let it heal up.
So you don't move it?
You're right, a couple of weeks or something like that. But many people tear their ligaments and never see a doctor at all.
I know.
So most of them heal up. But a bad one, you'll have an unstable ankle. If you tear the ligaments, it's going to be floppy.
Right.
Okay. But this is nasty. That must have hurt too. Here's some avulsion sites here. Remember our pelvis? We've got the greater trochanter here, the and the spines. This is where this anterior superior iliac spine, that's where the sartorius attaches. That's the origin up there. The inferior spine is where the rectus femoris attaches. Okay? Your psoas muscle and your iliacus are going to come down here through the inguinal ligament and attach to the lesser trochanter. Okay? Your hamstrings are going to attach to the ischial bone here. So a lot of these places where bones attach get pulled off in injuries. Okay? Very often in adolescence and sport injuries. Okay? So I just, again, I'm just showing you how they attach there. And you can see all of them but the rectus attached to the greater trochanter. The rectus comes up and attaches to the iliac bone. Okay? Sartorius is way up here. So now, what looks like it's missing here? And as you can tell, this is an adolescent because we still have growth plates in the iliac crest there. A 16-year-old athlete.
What's that thing?
What's that thing on the bottom?
Something extra.
Yeah. Well, besides the package right here,
Yeah.
this is a hamstring. He's pulled off the whole ischial tuberosity. See, it's nice and round over here. It's flat here. His hamstrings have pulled the bone right off.
Wow.
Okay.
What would cause that?
Any kind of strain, overstretching the hamstrings.
Yeah.
What's all that white stuff like right there?
Weightlifting could do it, yeah.
So,
But any kind of, you'd be surprised how easy it can happen.
Like if
you
he
know.
got hit in the back and then football.
Or
Well-
football?
Could that
I was about to say
not-
like a baseball.
Well, let's see.
Or maybe if he got hit in the turn.
Deceleration and acceleration injuries, you know, if you're just maybe not warmed up enough or something, just the act of, moving that leg, trying to flex that knee real violently can pull the hamstrings off because that's where it's attached. My brother did his sartorius in New Zealand when he was in high school. He was running track. The gun went off. Boom, first step, he pulled the sartorius right off the iliac bone.
so what is
Is
it?
this a posterior view or an anterior?
No, it's anterior.
It is anterior.
AP usually.
Okay.
So what is
This
it?
is all
when you-
normal. This is just DAS in the bowel and that sort of thing. Everything else looks good. Trochanters are all there. So,
What is it when you pull a groin? Is that more pulling a muscle?
that's more like the gracilis
Okay.
or the adductors.
Okay.
Yeah, when you strain the muscles close to the pubic bone.
Okay.
Here you go. Another adolescent. Growth plates here in the iliac bone. See that? What looks like it's pulled off?
The hip.
Yeah.
The hip.
No, this.
It's like
The-
it looks like it's lower.
It's like
No,
uneven.
go inside more. The little pointy.
I think this is just the way the
Oh,
X-ray
okay, never mind.
is turned a little bit.
There's an extra piece floating out on this side. That little
Right here?
piece.
Yeah.
Yep.
Left,
Yeah.
yeah.
He's pulled, this is sartorius, he's pulled off the anterior spine. It's missing there. There it is. Sartorius has dragged it down. Okay. I want to speed up a little bit so we can do some review. But remember, if anybody wasn't here last time, the test is Thursday, not Tuesday. Okay, so whatever we don't review, now, we can review Tuesday. Okay. Again, adolescent, growth plates. Okay, even a growth plate in the trochanter. Okay. What's pulled loose here?
Right under the head.
That piece down there under the
Yeah,
female.
good eye. You're looking for that? That's the lesser trochanter. The iliopsoas pulled it off. So there should be a lump of bone right there, remember? The lesser trochanter. So this is an iliopsoas injury. What are we doing here?
The calcaneus.
Over here. Start over here.
Yeah. You do.
Yeah.
All this looks pretty good. This is what your talus looks like, your navicular, your cuneiforms, the cuboid, the calcaneus. Okay. This is the end of the calcaneus.
Yeah.
Exactly.
So the Achilles tendon is pulled it off. So that's nasty. They're gonna have to go back in and pull that down and pin that back in there because you can't get around with that. So
Is that just from like stubbing your toe?
this one,
That's a break right
that's a
there.
break right there.
Yeah.
On the fifth metatarsal.
Yeah.
Oh, yeah.
What muscle attaches right there?
Oh, the
The
lateral.
brevis.
Peroneus brevis.
brevis.
The peroneus or fibularis
Short
brevis.
one, the brevis,
It
yeah.
attaches right there, and this is a typical ankle inversion injury where
Really?
you strain, you pull it this way, you're stretching that tendon, and you pull the bone right off. So these are sesamoid bones right here, the two round ones. Around the big toe and in the thumb, you're going to see these real often. So these aren't abnormalities; these are just extra bones that develop in the tendons, just like your kneecap. Okay, but so these are normal. Those are called sesamoid bones. And this is a relatively older person. You see some thinning of the bones here. Okay, it looks like a little osteoporosis. So that's why it probably didn't take too much of an ankle sprain to break that. We're almost to the end here. I just wanted to show you what bone cancer looks like. This is fairly far advanced, but you'll notice it's calcified, it's bone tissue. It's growing, it looks like bone, it just looks like abnormal bone, right? So it's calcified just like the rest of the bones. This is in the femur, okay? So this would be a pretty good lump in the thigh. And this is the kind of thing where they amputate. I mean, you're not going to fix this. And also, so you know, when you talk about carcinomas, you're talking about epithelial tissue cancers, like the GI lining, the lung, the skin. Those are all carcinomas. When you talk about bone cancers, that comes from the middle layer of the embryo, a different type of tissue, and you call these sarcomas. Okay? So you can talk about bone cancer, but they're never going to call it carcinoma. It'll be a sarcoma type of nomenclature. So. But it looks like abnormal bone. Metastatic cancer that goes to bone doesn't. It tends to look like a moth has eaten out the bones, like this. See how much of the ilium is gone here? Much of this joint is missing. See, over here is the acetabulum. It's missing here. See, it doesn't look like bone. It looks like it's been eaten out. Okay, that's the only point I want to try to make with those two x-rays. Okay.
GPS or something?
I'm sorry?
What's the little bead?
That's probably a radiation pellet. This is probably a woman with ovarian or uterine cancer or something like that. It looks female to me. I'm sorry?
My mom, her skull, they thought she had bone cancer like that because her skull was like thinning parts on it.
Yeah, the moth, that's the name of the disease I was trying to think of. I just can't come up with it, but I had maybe 2 cases of it in my career.
And like you can feel like,
Depression.
Yeah. And like she's got it right here and you can feel.
It's just on the tip of my tongue, but I can't come up with the name for it. It's a problem with calcium reabsorbing from the bone. Okay. Oh God, it just almost came to me.
Don't you hate that?
I hate it. Yeah.
Google.
You Google moth-eaten bone, you'll probably get it. But this again is metastatic cancer. This is all normal. This is air in the bowel again. Okay, those aren't tumors. So, but where you see the bone thinning out, most of this trochanter is also involved. Okay, compare the two sides. Okay, so okay, that was the end of that. So you got 20 minutes to go all the way back to the beginning if you want.
Yeah, that's all.
And I may have to start the neuro section in lecture on Tuesday because we can't really throw a day away. But I'll be willing to go through slides in lab too. Okay, anything you want to cover or any processes or whatever. The big thing, besides the nomenclature I was giving you, just to know what those terms like, myopathy, what does that mean, or a myogram, what is that? What's tetanus? What is or complete tetany versus incomplete tetanus? Things like that. Those terms, just have a basic understanding of the definition. But the concept that's important is that whole action potential muscle contraction process, because there's going to be at least 7, 8, 9 questions on that kind of stuff. Okay. I don't think I have any on the lecture test, but on the lab you will have to name a couple of muscles, or at least tell us why the muscle got its name. Okay. Did it come from its size, its shape, the number of heads, something like that. Okay. Its location. So just sort of be familiar with these little terms. Parallel muscles, that's pretty obvious. I don't think that's any real conceptual problem there. Circular muscles like the orbicularis and the oculium oris. Convergent muscles like the pectoralis start with a wide origin and go into a thin insertion. Okay. And how do you describe the action of the pectoralis major?
It pulls it in.
Pulls your arm forward.
All right, yeah, okay. Watch those B's and D's, okay? It adducts the humerus, it pulls in the humerus, okay? Think about it this way, if it's hard to figure out what muscles are doing, think about, just put one finger on an origin and one finger on the insertion and try to get them closer together, because that's all that's going to happen. The muscle's going to contract. So think about what has to happen to the humerus if it's out here and that gets closer. You're going to have to pull the humerus in, so it has to adduct, okay? So let's just say the deltoid. If I put my finger on the insertion and the origin and I try to make those closer together, what's going to happen to my arm? It has to go up, okay? So you know that that's an abductor. Okay? Same way with any other muscle. Just think about pulling the two ends together, what's going to happen to the moving part, okay? That's how you can tell. And then you just have to know the terms to describe that, okay? Is it rotation or is it circumduction or whatever, you know, just that sort of thing. But no big questions on this test like that. Pinnate muscle, just know what it is. Oblique fibers, anything like that. Okay, multipinnate, bipinnate. But the trick is that the fibers are coming in at an oblique angle so that you get that transmission effect. You get more power in low gear, basically. Okay. And that was just to show you the arrangement of the fibers. The only two aponeuroses that I'd like you to know, be responsible for right now, you can throw away the ones in the abdomen and the lower back, okay? But the Galea aponeurosis on the top of the head and the central tendon of the diaphragm, these are considered important aponeuroses, okay? So, and remember, when we put the Galea with the frontalis and the occipitalis, we get a whole muscle group here that we call the epicranius.
Right.
Epicranius.
Okay? And then don't forget what a retinacula is. It's that tendinous band, fascial band around the wrist and the ankle that fixates the tendons and holds them in place. Remember that when we're asking for a histological name of a tissue, if you're looking under the microscope or if you're looking at a picture or that we might show you, we might have that poster that's on the wall over there. And we'll say, what is the histological name for the tissue in B? You know, this is how you get it. Okay? Skeletal muscle is voluntary striated skeletal muscle. That's the histological name. Okay? Cardiac muscle would be involuntary striated cardiac muscle. Smooth muscle has no striations and it's also involuntary. So involuntary, non-striated, smooth muscle would be the full histological name. Okay? So just like stratified squamous epithelium, blah, blah, blah. It's the same kind of thing. The histological name. Don't get the epi, peri, and endomysium mixed up. Okay, I'll have at least one question about that. Epi goes around the whole muscle, okay? And perimysium goes around the smaller fascicles. Endomysium goes around each muscle cell, each muscle fiber. Okay, and you're gonna might as well learn it now because the nerves are the same way. It's the epineurium, perineurium, endoneurium for the nerves. Okay.
Oh.
Okay. I will give you a picture where you're going to have to name A bands, I bands, Z lines, that sort of thing. Okay. But from the Z line to Z line, that is one sarcomere. Okay. This right here kind of throws you off. It's not really out here and here. It's that Z line to that Z line. That's one sarcomere. Okay. But the I band does cross the sarcomeres. Okay. All that light area right there on both sides of the Z line is the I band. The A band is the darker one. And here's a good shot of, if this is relaxed, you can see that when these walkers pull the actin towards them, the Z line is going to move toward the dark band, and you start to lose the I band. Okay?
We have to know the actin and myosin.
Yeah, and the names of the fibers. But the actin is the thin fibers, the myosin is the thick. When you start twirling all those walkers together, you get a pretty thick rope of stuff. Okay? So they call that the thick fiber. The actin that it walks on is the thin fiber. That's a pretty picture. We describe this as multinucleated. Okay? Most cardiac muscle and smooth muscle is mononucleated. It has only one nucleus. Whereas skeletal muscle, you get very long cells, so you have multiple nuclei along the length of it so that they can turn out the RNA to make protein all along the muscle cell. One muscle cell goes from tendon to tendon, okay? Which cardiac muscle doesn't. It's microscopic. It's not much bigger than the nucleus itself. Okay? So, remember that when the action potential is moving along and then drops into that T-tubule, okay, until it hits that calcium door in the sarcoplasmic reticulum that's in blue here, that's going to dump the calcium all over the sarcomere, okay, and get those things to fire. You may not have this one, but you have that one.
Yes.
It's the same thing. Just different artist representations. But remember, the sarcoplasmic reticulum is where the calcium is stored. It's just another name for the endoplasmic reticulum. Okay. And let's see, terms here. We understand, or I hope you understand why the membrane, when it's polarized, is negative underneath the membrane. Okay. Can anybody just sort of verbally explain that to me? Like it's an essay question? Just sort of say what happens or why?
Well, the potassium first goes out through the leak, and then it gets a negative charge underneath, and then basically what happens is you get to that chemically gated sodium channel, which is where the one that starts with an A that I can't remember. That's it. Kicks open that channel, and then the sodium comes in. After that, it just goes through the voltage gated channels, assuming that it got enough of a charge from it coming in, and then it goes down to tubules and does the calcium and
Good.
stuff.
That's what you need to have in your head, okay? Because I'm going to ask you questions about the process. If it was an essay question, that's all I want. Just explain to me what's happening.
Do you want to know about, as far as making sure that we know that it's when that potassium leaks out, that the last one can't get out, and that's where we get that negative
That's
70.
where you get right there.
And then the threshold's of negative 55, and that's where.
Right.
Is the threshold where the sodium starts to
Well,
come into the.
some of the chemically gated channels might open if there's a low acetylcholine.
Okay.
But if not enough of them open,
Okay.
you'll get a more positive voltage, but it won't be enough to fire the voltage gated channels.
To hit the threshold.
Yeah, that's what we mean by the threshold.
Okay.
So it'll go back to normal.
Okay.
So, but if enough acetylcholine is dumped and enough sodium then goes through and fires the voltage gated sodium channels, that's when you get above threshold and you get a depolarization.
Depolarization.
So acetylcholine is basically the key thing.
Is the trigger. Is the trigger from the nerve, right? That's what the nerve is saying, here, have some of this. And it opens up those chemically gated sodium channels.
But you have to get enough of a charge from those to do the voltage gated channels to
So-
keep it coming in.
So we're polarized to start with, we're negative on the bottom, positive on the top. When we depolarize it, we're inverting the charge to positive, which is why we're going in a positive direction.
Okay.
Okay? And that's depolarization. This is when the sodium is rushing in. This is when the sodium channel stops,
The sodium.
closes, and the potassium channel opens. Then you get potassium rushing out again, and it overwhelms that positive charge that was there, and now you go back to negative again. Okay?
This is where I want to make sure that I've got clarification. This will just kind of continue to happen down the cell until it gets to those T-tubules, at which point the sodium goes down those, and that's what opens the calcium.
Exactly.
This just keeps on happening, assuming you've got enough of a charge.
Well, it may only happen once.
Okay.
You know, the nerves drops the acetylcholine once.
Right.
If that's enough, you're going to get that action potential move all over the muscle cell. Okay? It's going to be a wave because it's going back to normal behind the wave.
So that's what I'm saying. It's just going up and down, up and down, up and down. Boom, gets in the T-tubules, and that's what hits that calcium.
Yeah.
Okay.
But everything behind is now back to normal.
It's going back to normal because of the sodium potassium.
And the acetylcholinesterase has destroyed the acetylcholine, so it's not stimulating anymore, and that's going back to normal.
Okay.
And the sodium potassium pump is making the concentrations go back to normal. So behind the wave, behind the positive wave, everything is going back to normal.
Yep.
But
Okay.
if you're running, obviously it's not going back to normal.
Oh, no, because you're
perpetual, right,
Yeah,
exactly.
you're continually stimulating
Right.
the muscle. Okay, but all this happens so fast that you can go back to normal pretty quick. I mean, that's 5 milliseconds, 5 thousandths of a second. Okay, So it's pretty quick.
So the depolarization is that sodium coming in and making it positive again.
Right, right. That's the depolarization right here. That's what's on the graph. Okay. Now this next one just sort of says everything we've been just saying. Okay. This tells you when the sodium channels open at threshold. The sodium channels start to close. The potassium channels start to open. The potassium is going out, but you're going more negative because of that. Okay. And there's a little overshoot, but then everything goes back to normal. Okay.
What was the overshoot called again?
Refractory period. Yeah.
Refract. Okay.
Yeah, don't worry too much.
Don't.
That wasn't a question. We've already gone over this. I would just be ready to label the parts and pieces here. Okay.
Would it look like that?
I might even put that exact picture on there. Just be familiar with dystrophin and titin. Dystrophin connects the sarcomere to the cell membrane, to the sarcolemma. Okay, that's all you need to know. Don't worry about this numbers or whatever.
What it does?
I guess we need this review.
Yes.
Dystrophin attaches the sarcomere to the sarcolemma. Okay, otherwise the contraction might happen, but the cell won't contract. Okay, you have to pull the cell wall in with it. The titin is just a spring that pushes everything back to normal when it's over with. Okay, so just those two little facts in your head will get you any kind of true-false question I might give you or something.
Would you mind though? And I know you did it once before, but just I know titin is the spring, but basically, can you give us a quick of how it works?
You mean the walkers and things like that?
The titin, how it
Just think about it. Here's the Z line.
right,
This is all going to get pulled in.
right with those little
So this spring is going to get compressed.
tight,
So when you don't want it to walk anymore,
Right.
the spring just goes boing and pushes
and it's the
it.
titin that basically kind of unleashes it.
That's the titin.
Okay.
No, titin is the spring.
Oh, the titin is the spring.
Yeah, titin is the protein
Okay.
spring. Okay.
Titin is the spring.
Name of the protein.
So I should put is the spring, not is a spring. Okay.
Okay. Neuromuscular junction is a term that should be in your vocabulary. Basically, that's just where the axon meets the motor end plate on the muscle. Okay. The synapse is the space between the two. This is where the acetylcholine is going to be released into. Okay. You can even see the little vesicles here on the axon side. These have all the acetylcholine in them there. Okay. So they're going to be opening up and dumping that in. The chemically gated sodium channels are going to be on these little appendages here. Okay. This looks like a giant mitochondria here or something. That looks like might be a couple of them. Okay. And acetylcholine. Okay.
The A word.
Be familiar with the A word. What is it? What does it do? This pictures. The term intercalated disc. Okay, that's the separation between the cardiac muscle cells. That has all those gap junctions that allow the transfer of ions so that you get the rhythmic contractions. I would have that in your vocabulary. Okay, intercalated disc, full of gap junctions. This is a pretty good shot of cardiac muscle here. You can see how short the cells are. They're nothing like the skeletal muscles. They're not much bigger than the nucleus themselves sometimes.
So what is the intercalated disc?
It's this line. It's the cell wall between the two muscle cells. Okay? So you're going to see those lines in cardiac muscle. You won't see them in skeletal muscle. Smooth muscle. I guess this is one of the better representations to show you how it's not striated. Okay, you don't see any of those bands or anything like that. It's microscopic. The muscle cell isn't, more than a few times larger than the nucleus itself. The dark lines those are the nuclei, not the cells. Okay? That's the nucleus, so you can see the outlines of the bodies of the cells. Okay? So they're microscopic. It takes a lot of them to get any sort of tissue to contract. This just happens to be the intestinal wall where you have it going in longitudinal and in circular bands, okay, which is what guides the peristalsis to get everything to go through. Okay.
And And that's voluntary
No,
or involuntary?
unless you can talk to your intestines. It's
Do it
I don't know
involuntary.
why I wanna confuse.
Yeah, voluntary, the only one that's voluntary is the one you can move, that's
Yeah,
skeletal.
the skeletal.
Okay, you can't really tell your heart what to do or your smooth muscle what to do. Okay, so that's involuntary. And just another picture of smooth muscle and the vascular structures there. And this explained why there were no striations, because the sarcomeres are not lined up in bands. Okay? They're individual little groups of sarcomeres arranged in crisscross patterns, so that when a cell like this contracts, it will contract, but you still have no bands. Okay? So that's why it's not striated. Okay? And the little junctions there look just like desmosomes. Okay? But then you have gap junctions, where this is where the ions can cross through. The important idea for this is just to realize that some types of tissues have those gap junctions so that you can get rhythmic contractions, where all the muscles can work together. And that would be things like in the heart, in the intestines, in the uterus, okay? You'll have these kind of contractions or junctions so that they can stimulate each other and you get rhythmic contractions. Whereas in something like the smooth muscle that's not under your control, like the smooth muscle in your iris that controls how much light gets into your eye, you don't want that to be any kind of a rhythmic kind of thing. You want to find out how much light you need and set it there, okay, so it doesn't move. So you control each one of those smooth muscle cells independently, okay? And so that's what we mean by multi-unit. It almost sounds like it should be the other way around. Multi-unit should be multiple units, and this should be a single unit, okay? But this is called unitary or visceral smooth muscle, so it works in unison. You could look at it that way, whereas these do not. They have to be stimulated to work, and that's called the multi-unit smooth muscle. The Leber principle, you know I'm not going to hit this too hard, but I might give you an example of a joint or something and may ask you to sort of think about what type of lever it is or something like that.
Do you want to ask a question?
I have no question to ask because I'm kind
Okay.
of better. I haven't grasped this lever stuff, and I don't know.
Believe me, it won't be more than one question.
Okay, great.
So
I can probably.
don't spend a lot of time.
Okay.
So what would that be
So
an example of?
Like first class lever, second class, is that what you wanna know? Like if you ask a question,
Yeah,
that's.
yeah.
Then you might have a
Yeah.
choice of what we
Yeah.
use.
Well,
Okay.
if I said the elbow joint, what kind of lever is that?
Third, because it's a catapult.
Sure, it's the catapult, yeah. Something simple.
Okay.
Something simple.
All right. Simple I can do. Yeah.
I would just be familiar with the term myopathy and dystrophy. Myopathy is basically any muscle disorder, okay? If the muscle fibers are not functioning for whatever reason, you can call that a myopathy, okay? But dystrophy is sort of a special genetic group of diseases, okay? Then we talked about receptors and the little PBS, the energy sources. Well, I gotta let you go. I will have plenty of time to review this again, okay?
Is it that time?
Yeah, that's fine.
Wow.
Quick.
Videos may